I think we are now connected.
Yes, sir. Just
Just give me a signal. Then.
yeah. Okay, sir.
Good afternoon, friends. In our continuation of the webinar series, we are fortunate that Dr. Anand Thakur is with us today, Tuesday afternoon, 2:30 p.m. So this is the next in the series. We started with plate fixation principles, then interlock nailing. Then we had a wonderful webinar previous Tuesday. And today is the time for tension band wiring and a potpourri which academically you would relish, and you would relish it for a long time. If the lockdown continues, next Tuesday also the webinar continues. In case the lockdown is not there, this would be the last in this webinar series. So I welcome Dr. Anand Thakur. We have with us Dr. Anand Thakur, Dr. Ashok Sham. He is providing us the Zoom platform, and Dr. Alok Umbre would be shortly joining. And you can shoot your questions to Dr. Alok Umbre, and we'll be taking up the questions at the end. In the presentation, sir would be indicating us when to have a question and answer so that we will have a detailed discussion that time. So sir, most welcome everyone, all medical colleges, postgraduate students, lecturers, and the practitioners. They're all eager to learn the basic principles from you, sir. Most welcome.
Thank you. This afternoon, I'm going to talk into three sections. First is about tension band. And it's not a routine pass the wire and loop it around of thing, but some fact, thought-provoking things about the tension band and the related affair. The second half is about bone healing, which is essential but fairly dull for an afternoon talk. But the story I am going to tell is fairly new and not so well known. So those of you who could manage to keep awake should be able to get good stimulation out of that story. And lastly, I'm going to show you a trick which if you acquire yourself, you get proficient in that. All your patients with fractured neck femur will bless you moment you perform that trick. They will be in perpetuity in your favor and will be obliged to you. So starting with the tension band wiring, what is a tension band as such? Let's see, this is a column that we all know, and if it is loaded centrally, then the stresses developed are equal on both the sides. So the only force that is working on this column is of compression. Now we change the scenario. There's a statement that column is strongest against centric compressive load. When we load a column centrally, it can withstand extremely high loads without giving way, which is a special property of a column. And in practice, in life, you will see this many times. On a suspension bridge, you can see the weight of the bridge is passed on to the top of the columns through these cables. And these links, they pass on everything there. And the top of the column is loaded in compression and takes huge load. The example we all see Golden Gate Bridge photograph, which many of us show when we are on this net. That's a compressive load here. If you want an example near our home, I have here this ceiling. You can see that all the weight is transferred to the top of these two columns, and then it is got down. These two columns are under compression. That's why they are very strong. And instead of one, there are two columns. So we should be very happy that we are very safe while traveling on this road because these two columns are taking all the compressive load and maintaining the stability of this span from here to here. A different situation. We want to load this column in a slightly eccentric way. So what happens then? Then the forces are a little different. is not compressive all the time, but on one side they are compressive, and other side they are tension. On the inner side you have compression, and the outer side you have tension. Also, you will find the line of forces is eccentric. It's not right in the center, like in the centric loading. The eccentric loading, the tension line moves out like this. It's maximum on the farther side. So total stress now is compression stress plus bending stress. Because it is off center, because it is eccentric loading, there will be a bending moment at this point as well. So you have a compression load, there is a bending load as well. You transfer that knowledge to this column which is broken but is supported on spring. If we load it centrically, you can see the spring is compressed. That means the pressure is equally divided over these two loads. Now, if we do it on eccentrically, it will tilt one side. Should we want to stop this tilt, what can we do? If we apply a band here, just a piece of non-elastic material between the two, then it will not bend the way it is doing now. You can see here, as soon as the power is loaded, this band gets under tension. And because it is working under tense condition and stopping that unequal load, it is called a tension band. Band which works on principle of tension, which is actually anti-tension, but works on the principle of tension, so we call this as tension band. Many examples you can see in the industry or in day-to-day life. These two strings are holding that huge piece of metal. And again, here the same thing happening. So many examples you can see in day-to-day life. These are all tension band wires which we see every day. Another set of example. In our orthopedic practice, this kind of fixation is so popularly known as tension band. It works on eccentric compression basis, which we'll examine in later. Now, a bone like femur is loaded eccentrically, and then it develops a compression on the inner side and tension on the other side. And between the two, there is a neutral axis present there, and the works can be different out. To treat a transverse fracture, we many times put down a plate on the tension side. We know this is the tension side, we put the plate here. It works as a tension band. So that tension band could be any implant, any appliance which will resist the tensile forces which are separating the two pieces apart. So it's only a principle, is a technique which converts distraction forces of extensors acting on the fracture line into compressive forces. Application of an inelastic band under pre-stress conditions. Two important things. The band should be inelastic. You can't put a rubber and expect it to work like a tension band. And it should be pre-stressed. That means sufficiently. Same thing with the plate. If you don't apply little tension on that, you don't apply compression on the outer side, the plate doesn't work as efficiently. To be pre-stressed to work the best. The implant alone does not provide any connectivity. It doesn't do anything else, but it is the combination with the antagonistic deforming muscles that it produces uniform compression at the fracture site. What from each other, it holds them together so that their destructive force is converted into a compressive constructive force on the opposite side. It guides the compression forces in the right direction. That is what it does. But for that, the condition is that the opposite cortex must be strong enough to withstand these compressive forces. As you know, the tensile forces on the outer surface of the femur are very strong. So unless the opposite cortex, the middle cortex is strong enough to withstand those kind of loads, this thing will not work or will collapse. If the, as you know from experience, if the medial cortex is crushed, is comminuted, the tension band wire does not work. The tension band plate does not work as efficiently, and you have to use some other technique. Band on the tension side is the tension band. It must be pre-stressed. It's important. It must be pre-stressed. You cannot uh, just apply it like this. So pre-stressed means it should be tightened enough. The wire should be tightened, and the plate should also be compressed. That means we pre-stressed. It must be strong enough to withstand the tension load, and the opposite cortex should also be strong. Otherwise, it will break down under the compressive loads, which is not satisfactory. The joint movements associated would also produce more tensile stresses, so it should be able to withstand that kind of load, not only of the muscles which are going to take away the two fragments together, but also the joint forces they should be able to withstand. Tension band wire, the principle was first found out or invented by Ferdinand Pauwels. It is Hardy Weber, a Swiss surgeon, who used that to fix a fracture. And that is now we commonly call it tension band wiring. What he did is applied Powell's biomechanics to counter the pull of the quadriceps or triceps tendon by applying wires on the tension side of the ulna and patella. That was his idea, and that has worked very well. Give you an example. This is a rod with a small break, and there is a load from this 3-point bending. So 2 points are supported, and this is the third point in the opposite side. For example, the ulna, you can see that the 3 points are loaded like this. And if we apply a band here or connect them together, then the loads are contracted and the bone does not break. Having reduced, we just put a band here and take away the loads here. It works as a tension band. But when the load is applied, the opposite cortex opens up. It doesn't compress consistently because the application of load is eccentric. When it is eccentric loaded, the inner side opens up. Whenever you apply this kind of tension, but you will see the inside opens up. But when you flex it, the opposite pressure is applied and this closes up to some extent. So this is the drawback of this principle of tension banding. You apply the tension band on the far axis for fiber, which is essential, but that will open up the opposite cortex to some extent. You can see in this, this is opened up like this, properly done tension band when flex it. Then the elbow, the two types of loads are applied to the olecranon. Compression force along the long axis of the ulna and shear force as the forearm is flexed due to muscle action. Along the long axis of ulna, you have the compressive force, and as the muscle is flexed, there is a twisting force applied to it, and you get two types of load. One is compressive, and the shear force in the forearm is faced due to muscle action. When you are just holding the elbow at 90 degrees, there is a compressive force along the axis. But when you bend it, which you are likely to, then there is a shear force also applied. Because the muscle action is slightly rotating, the torsion is converted to a shear force at the fracture side. With this repeated movements, you get a joint incongruity. When we talk normally about extension band, we do not consider these things, but this is the biomechanics, and we should know that there would be some degree of incongruity in the joint line, which is inherent in this technique. You can see that slowly a step develops and the joint opens up. This is because of the resultant forces playing in wrong direction, they are equal and opposite. So resultant force is not working in the opposite direction like this, but it is working at a tangent. So with that continuous force working like this, a step is likely to occur. Joint incongruity and a step there. AO recommends that we should put a wire like this in the opposite cortex, not the medullary cavity, but it should go and fix itself in the opposite cortex. But even with that, the step will occur. It doesn't stop. There we are. Whether it is in this way or it is holding the cortex, still the step takes place there. Tension side is compared to pull the joint line apart. A step develops near the joint and joint surfaces become incongruous. Again, shown here very well. Here we are. So this drawback of tension band wiring is worth noting and understanding why it happens. Because of the ever-present shearing forces, eccentric tension bending tends to lead to of steps. With every moment produces disturbance within the fracture, which can lead to secondary distraction. So this is not a dynamic osteosynthesis because the forces freed during the movement are destructive. It dislodges the fracture fixation. Your reduction is lost because of this. The more the force and the more the eccentricity towards by means of wire tension bending, the greater are the biomechanical disadvantages to this. So working at the ulnar, the distraction forces are much higher than the compressive forces. Now wire backs out at the point of the elbow. Like this, you can see here. To restrict their movement, anchoring them in opposite cortical layer is recommended. But the Krishna wires do not loosen on their own account. They move only if they are not made fast by a taut tension band wire. If the tension band wire is not as tight as it should be, then there are more chances of the OK wires backing up. But if you are putting in the cortical layer opposite as it is recommended, they should be under tension. They should be slightly bent by the tension band, figure of it bent wire which you put on, so that they are held down, they are slightly bent, so they are exerting again 3-point pressure on the place where they are. So that gives them the strength. If they are loose, the tension band is loose, the wires spill back out. This is another mechanical example to saying when the tension band is applied, there is something like a hinge. And when the hinge is applied here, it will close up at the side. This figure shows a screw being passed. When one wants to apply a tension band wiring to an osteoporotic patient, the wires are likely to cut out. To prevent that, one passes a cannulated screw across the ulna, and then the tension band wires are then put through the wire, through the screw, so they do not cut through the bone and remain there till the fracture heals. So this is a trick for osteoporotic bones when one wants to do a tension band wiring. This is a reliable trick using a cannulated screw, and the wire is passed through that and come down to the tension. Many times people think that putting a screw will do the same job. Sure, it will compress it, but then it is compressing in the middle section. as the biceps and triceps will pull in the directions which are shown here, this side will open up and will not heal. In the hinge example here, the hinge instead of being placed here, is now placed in the center of the matrix. So when the force is applied, it opens up posteriorly, and which is not desirable for us. There's an example, this fracture, otherwise with tension band it would have been okay, but the surgeon decided to do a single screw, probably percutaneous, I'm not sure. But it didn't work for reasons I just said. Over and above, if he had put in a tension band here, probably it would have worked. It would have worked like a 2K wires and it would have worked, but the way it was done, it didn't work. So ultimately it was removed and established NAN engine was later on treated with this plate, which is again put on the tension side. In this situation, compression was applied with the help of Verbush clamp, and then the plate was applied. So in 2 months, the entire non-union went. Mind well, there was no bone grafting done there. There was no gap. And following the BNH theory, we didn't put any bone graft, and in 3 months' time, the union was perfect. Now, considering these patella fractures, the parallel wires only serve as the rails along with the bone fragments can slide. So, what is the best position for this for the wires to cover? Where shall we put the wire? Here, 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 or here? Let's examine this. If we put the wire at an angle of 60 degrees from the center, from this is 90, so at 60 degrees we insert the wire. Let's see what are the forces acting. The quadriceps pull will be quite strong, and the patellar section would be quite low. So the resultant force would be acting on the sideways. That means it will produce distraction at the fracture side. If we pass the thing at 60 degrees. So we consider another situation. Now we pass at the angle of 20 degrees from here, and the K wire is passed here. The resultant force is good. It will cause equal amount of pressure on the fracture line, but the pin is so far laterally that this bone may not be able to withstand the pulse, and it may result in a break off. So this is also not a nice position. So third position that we can say, we pass it at 45 degrees. From here at 45 degrees is past the spin. Now the quadriceps pull is sufficient, but the patellar pull is also quite strong. With the result, the resultant force which we want compression against this fracture line is maximum available here. So between the three positions, 20 degrees and 60 degrees have their disadvantages, while 45 degrees is the best position to apply. So whenever you want to pass these two pair wires, you should take a point 45 degrees from the center of the patella on either side, and that is your best possible position to insert the wire. Always bend the tips of the wire, otherwise they can come out and get lost. Your reduction will get lost. Everything is so always bend the tips so that the wires are retained in that position. It's another effort to show when the knee joint is bent, there are tremendous amount of forces working. Here the quadriceps is pulling in this direction and the patellar tendon is retaining its position, but because the action and reaction equal in opposite, so this pull and quadriceps pull match each other. As a result, the resultant force is pressing hard like this. So there is tremendous amount of tensile forces here and compressive forces on the patellar side. Another theoretical example, that two parts of the patella, one side is the quadriceps tendon pulling hard, other side is the equal reaction from the patellar tendon. If you apply a tension band here, it holds two together and presses the point here. The placement of the hinge at the proper place will cause the good compression at the fracture side. The material should be inelastic and it also should be easy to handle. We have been using stainless steel wires. 18 gauges are most frequently used. They do not knot easily, but they can be twisted very well. They elongate on excessive pull. They're ductile wires. So we have always said that the band should be inelastic. So in principle, the wires are not as inelastic as we would like to have it, but they serve our purpose. But when you examine it in mechanical details, then we will find that it's ductile and is not a very suitable thing. It hurts after swelling subsides, wires you can see, but the advantages are cheap and easily available. We don't have to really work about it. Um, they break and they cause pain, so there is a high reoperation rate secondary to the painful hardware and wire migration. These two causes in Patel tension band causes reoperation. Let's see what is the function of patella. It acts like a lever for knee extension. The quadriceps is weaker without patella. In those days when we used to do patellectomy, the quadriceps used not to be very strong, but understanding of mechanics wasn't very good at that time. So patellectomy was quite a fashionable operation. Not any longer. We want to retain even a smallest piece of patella should be retained and should not be sacrificed in case of fracture. It is very useful. There are large compressive forces on patellofemoral joint that we have said. As you can see here, the one side is on tension, and because of tension, it is produced on the other side, and we get here and the compression. So the outer surface is under tension, inner surface is under compression. That's why the, the articular surface is thicker than the non-articular surface. You would remember that the patellar cartilage, the articular surface of the patella is quite thick and strong, as because of the compression stresses. This also tells us about the Wolff's law, that if that they will respond to the pressures of the loads they are doing it. We'll consider Wolff's law shortly, but this is one example how the bone modifies itself depending on the pressures that they are working on, depending on the loads and the powers that they are working. When patella fractures, it is usually by the 3-point bending. There's severe pulling stress by the quadriceps and the equal and opposite stretch by the patellar tendon, and then the outer fibers give way under tension, tensile strength, and the patella. There's a transverse fracture here. It's a compressive. Patella fails in tension, or to stop that, or to bring back that those fragments which are separated because of the tensile stress, an anti-tension device is required. And tension band wiring is actually anti-tension band wiring. Because there are tensile forces that to be taken care of, we need an anti-tension device. What it does is holds these two pieces which are being pulled apart because of the tension. We put a plus and it's called anti-tension device. There we go. Anterior tension band, when we apply on the far segment, the compressive forces will take care of this and produce the fracture. But if we shift the tension band posteriorly, then the reverse will happen. Because the hinge has gone posteriorly, the opposite will take care. The tensile forces are working here, but the fulcrum has changed. And because the fulcrum is now at this side, the other side will open up. Had the fulcrum been here, this side would have closed. So when Weber first put forward his tension banding, it was something like this. He passed wires across the surface. There was no K wires. Later on, the K wires were done because of the forces that act on it. There used to be a slippage of the reduced fracture. That's why they decided to put a 2K wires, parallel ones. They modified it, and now we are using modified anterior tension band wiring. It is mainly passing 2K wires and then putting a tension band wiring. So modification has been a longitudinal Krishna wire, 18 gauge SS wire in figure of 8 loop over the anterior patella. This is what the now standard modified anterior tension band wiring recommended by AO company. How does it work? Converts again, say we have talked about this, but convert distraction forces, forces of the extensor acting on the fracture line, and converts them into compressive forces. So this mechanism converts the destructive forces to constructive forces. But just putting wires doesn't work. It is those muscle actions that really does the trick. In combination with the antagonistic deforming muscles, it helps produce compression at the fracture side. It guides the compression force. And if wires only serve as rails so that the fragments don't go sideways, but they are together for most of the time. Now we put a figure of 8 there. Should we put 1 or we should put 2? Recommendation is that you should put 2 knots in the tension band and tighten them simultaneously, giving equal amount of tension on both sides. You can see in this demo, even in Allah, a passed wire and 2 pliers are used to pull it apart simultaneously and twist them. The twist also should be in a fashion that both the wires are put up like this. We do not want to pull it in this way so that one single wire is running straight and the other wire is going here. So to do this, you have to hold both the wires separately into different prongs or 2 different pliers and then twist them together so that you get this kind of a twist. This kind of a twist is not recommended. This is the one you should always aim at. Now this figure of 8 should be vertical or it should be horizontal. Now this is vertical figure of 8 and what this is horizontal figure of 8. Now how these are different, how do we apply this horizontal figure of 8? We're starting from here, you go down like this, come up and then opposite side, back here and then make the twist. So you have started one loop from here, down, up, down, here, and here you can roll it up by yourself. So you have now 2 knots, then pull them apart and twist them. This makes a horizontal sort of expanded one. What are the advantages? When you do a vertical one, you have got pressure points only at 2 places, only those 2 places. There's nothing happening on the sides. But because you've gone an extra length, you have got 2 pressure points. So you got pressure on the proximal, pressure on the lower side. So this will be a more evenly pressing construct rather than this. So recommended is a horizontal figure of 8 across 2 K wires. Horizontal figure of 8 tension band wiring with stainless steel wire passed over the Krishna wire, bent at the tips. That is the preferred method that you can see here. We see there is a step always in the ulna as well as in the joint and the patella. So is there any way to get out of this? Shall we do that? I mean, how can we do it? If we use a different technique called bilateral tension bending, then it will produce optimum production of pressure and distribution of the compression. The compression will be optimum and distribution also will be even, and it will be an optimum neutralization construct, and the shear loads and the bending toe will be minimized. How to do that? Instead of passing the wires here, we pass a screw here and then there are wires. The central wire, the 2K wires are there, but the figure of 8 bandages go sideways. You can see 1 to 1 on this side, 1 to 1 on that side, and there's a screw beyond which it is done. So this one is pressed across like this. This one is pressed across like this. There is no extrinsic eccentric wiring pulling the things apart, but two wires which are pulling on this side and pulling in this side. So the force is now acting like this. So the fracture across is well compressed. There is no opening of that. So this is a different way of applying tension band, and theoretically, at least, it is much superior to what the other tension band recommended by AO. These are from the author's book, which I'll just show you in a minute. You can see the wires on this. Actually, these are not wires, these are cables. He recommends cables, not wires. But the compression is applied on sideways. Here we are, centralized wires, works wonderful. We apply tension band. If you apply tension band on both sides, it will nicely compress, will not shift, will not move, will not open up here also. Stands to reason. Another example in patella, how it is done to bands, instead of going zig, zig, zig like this, we are going one side this way, one side this way. And these are cables, not wires. Like here. Cable, the K wires are bent slightly on the sideways to give compression on this side. Again, this will be bent other way to give compression on this side. So the patella is squarely held together and gives a better result. Eccentric tension band give you more of distraction, less of compression, while bilateral tension band, most is compression, very little distractions in here. This is the surgeon who professed all this. He has worked this out very well in this monogram. And it's very logically put forward tension band principle. Somehow it has not picked up, but it is worth considering and it's worth practicing. Levitsky's tension band methods, they are very useful. Back to our standard tension band, where else can we use them? Greater trochanter, it can be used here in the greater humerus also. This looks very tempting, but in shoulder itself, metal doesn't go very well here. So one would think, oh, I'll just put a tension band wire and recovery will be very quick. It doesn't happen. It takes really long time for it to completely recover. May not recover. So recommendation these days is not to use this tension band in the humerus, but instead use those anchor sutures and then suture back that display space. Instead of this, the anchor sutures are far more effective and very kind to the shoulder, and the recovery is much faster with the anchor sutures. These are, of course, bread and butter for you and me. We often use them when the pieces are not big enough to hold a screw or the bone is very porotic. One should use tension band wiring, but tension band wire is to be done very precise. End of the clavicle also, one can use it as a tension band wire. It is quite possible. The principle can be used, but here there is no compression. No, the cortex has to be strong enough. If there's comminution, then this technique will not work. The metatarsal or metacarpal and two wires are just put up here. They will work as tension band and produce compression on the opposite side. Orthodesis of PIP joint can be performed. Orthodesis of wrist also can be performed. Even in spine surgery, one can use this principle of tension band by putting a loop behind for giving a counter pressure or counter traction, whatever is indicated. The principle is same. It can be worked here also. We use also this principle in plating. So that requires it's a little out of the way from the standard tension band, but the principle is there. So I thought I will take it up. As you know, in the femur, there is a neutral line, and when there is a pressure, there is a compression on this side and tension on the other side. Should the fracture occur, it is because of the tensile stresses acting on the outer cortex, and because the muscle pull, the both sides will be separated. Now to keep them together, we apply a plate that to under compression. Mind well, we are applying the plate on the extension side. That's why the neutral line, which could have gone far behind, which was otherwise going on the other inner side, now moves back towards the external, towards the outer cortex where it should normally be, because we have now nullified those tensile forces working on this side by this plate. So this is a tension band plate. If we apply this plate on the compression side, it will hold on for some time, but since it doesn't have the support of these muscles, in fact, the tensile muscles on the outer side will work against the plate, and eventually the plating on the medial side would fail because of this mechanical reason. Not necessarily the plate is weak or of poor quality, but the mechanics is not right, and the muscles will act day in, day out, and will loosen this, and it will break eventually. When you apply a plate, there are two kinds of compressions applied. When you applied with all your mechanism, applied a plate under compression, it will have, say, generated a compression of, say, 1000 degree, 1000 nms. But when more load is put inside, there will be compressive forces on the inner side also. So this is also working, and additional one will also work because there's a good contact, and this will be more while the load is being taken. But once the load is taken off, the situation will return to like this. So this is called static, which is present all the time, and this is called dynamic compression. That it will come only when there is loading on the side. If one moment is unloaded, it will go back to life. So this is again the dynamics is shown this way. This is static maintained, but it all increases after weight bearing when the plates are put in the right side. Application of plate could be very tricky. If you just apply compression, this side opens up, which is no good because of the stiffness. This will remain like this and may cause problem in healing. So how to get over this kind of problem while applying? We need to pre-stress it. Right in the beginning, we said that the tension band should be inelastic and it should be pre-stressed. This happened because this plate was not pre-stressed when application. This is inelastic for sure, but it is not pre-stressed. That's why the gap didn't work. So how to pre-stress it? This plate is being applied without pre-stressing, just a compression, the far cortex opens up. So now the plate is slightly bent. That means it is pre-stressed, and when applied here, it will close the opposite cortex. Of course, when you apply a pre-stressed plate in this fashion, you have to follow rule of application of screws from center to outside. This is very essential, from center to outside. So first screws that go on either side of the fracture line when you have pre-stressed this. Moment you do that, the far cortex come closer. When you put the second and third one, the entire cortex comes. So this is working again as a tension band. It is inelastic plate. It is now pre-stressed and then applied in the correct way. It will produce a compression and will defy all the tensile forces, divisional forces. So this was worth noting. The example also, the same principle has been repeated here. A straight plate will open up, but a slightly bent plate. Nowadays, we don't slightly bend, we make a sharp bend here. But this is also a good way of doing it. And again, but the screws have to go from center to outward, from center to outwards. If you put the last screws first, then the plate cannot expand, plate cannot straighten out. So this will not open, this will not compress, this will open up on this side. So remember, when you pre-stress it, you must apply screws from center outwards. Now, this is non-stress plate. This is stress plate. You can then adequate callus on. Let's talk a little bit about wires and cables. Wires we have been using, and everybody knows what a wire is like. Strength of a wire varies directly in the square of its diameter. That means thicker the wire, stronger it is. Thinner the wire, weaker it is. There is no effect. Effect of time on the wire is nothing. Stainless steel maintains its strength all throughout. However, it may break and fragment when it is subjected to motion. If it is rubbing against each other in a twisted way, it will break with time. Twisting is beneficial, improves the tensile strength, and again shown here the way it should be twisted. Both the pieces are to be taken separately and then twisted around over each other, not one over the other. Improves the tensile strength. 4 to 8 tons per inch or more than enough. If you apply 13 or more, it is diminished to a less than untwisted. So too many twists are no good. 4 to 8 tons are extremely good. In fact, with the first turn only, the whole thing stabilizes. Next 3 or 4 turns, we give it as an insurance that it doesn't reel off, it doesn't open up like this. Otherwise, the maximum stress is achieved by very first turn is the most crucial one. But normally up to 4 tons, 5 tons more enough. No need to go on to such a long one. The strength of the wire is reduced by repeated bending or by kinks, or if there are surface defects by instruments. If we are using real wires and if they are handled too many times, there are some surface markings, then that's a weak spot, that's a stress riser. If you use that wire again, it will break sometime while it is being used. So one has to be careful. Always use fresh wires, and if they are kinked or bent, they should be discarded. Very small diameter wires, they don't affect the blood flow supply, but there are wide bands, something 0.3 to 2.5. They could cause serious trouble. Thin 18-gauge wire will not make much difference. But earlier we had those some bands, or in between we had plastic bands which could be applied. Wide bands, 2.5 centimeters, 1 centimeter wide to 1 inch wide band, that could cause serious trouble to the blood supply. So they should be avoided. I mentioned Levitsky and his work. He says principle of tension band is good, but the application method should be changed. The way he has changed, he says don't use wires, use stainless steel wires. They are supple, they are excellent to handle, they're truly inelastic. But they need special equipment and they're difficult to obtain, and that's why they're expensive also. But he recommends that we should use braided cables, stainless steel cables. We need a special appliance to tighten them or to tension them, and a applicator which will crimp, applicator called Crimper. So once the cables are tightened, the crimp is put in so they don't shift anywhere. Like the small knots, they don't shift anywhere. You can see those smaller knots here. These are crimps. Crimps are here also. The wires are passed through this and then crimped, so it doesn't move. What is a cable? Cable is see each one is a small wire. So 8 or 9 wires are rolled together, and such rolled 8 or 9 pieces are again rolled together. That makes a wire. That makes the cable. So this is a single strand, make it into a larger strand, and such 8 or 9 larger strands are again woven together to make a cable. But they are very supple, not brittle like this. And this is a crimper. The 2 ends of the wire are passed through this crimper, and with the machine they are just squashed so they don't move. Here it is how it is. This is the crimper end. It's passed through this, and then it's crimped. So it stays like this, does not move, does not give any noise. Uses are many. You have seen this. It's not today's topic. So there's a little longish talk about tension band, but I tried to put in the different views. It's not a goody-goody view of tension band, everything works. There are steps and there are issues. And we should think about Levitsky's method of putting tension band in a different way. And if we can afford, we should also start using cables instead of standard gauge wires. The questions, we can do that.
Thank you very much, sir. It was not longish, it was absorbing and it was stimulating as well. And the orthopedic imaginations were getting stretched also. So it was nice to learn about horizontal and the vertical tension band. And Alok,
Sir, yes, sir.
I think you must also be stimulated by
Yeah, yes, sir, definitely.
and we must be having question and answers.
Yeah, yes, sir. Yes, sir. There's a few questions, sir. Sir, I will go ahead with them. Sir, if there are 3 to 4 part fractures in a bone, say patella or a proximal ulna, olecranon, can we still go ahead with tension band wiring? Will tension band principle work there?
Yeah, depending on the size of the fragment that you have, one could use small screws to get a bigger portion. There are two small pieces. You can put cancellous screws to make a bigger two pieces and then put tension band wiring. Or you can use a circlage first and then a tension band. But the principle can be used anytime. Thirdly, possibility you can use a cannulated screw to fix them first. And through the cannulation, you can pass the wires in the tension band figure of 8 and still use the principle. The tension band, today we discussed as a principle. Exactly what situation, how to use it, you can modify yourself and then make the best out of it. Once you have the principle, you can use it to your advantage anytime.
Yeah.
Thank you, sir. So there's another question.
Yeah, go ahead, Alok.
Yeah, if the now this was for patella, the fracture line is horizontal, but if it's a vertical fracture line, the same principle will work or not?
If it is a vertical fracture line of patella, first I have to imagine how it was produced.
Okay.
Unless there is a sharp instrument or a bar which is hit like this, it will produce a sharp instrument, I would think, a sword or something right on the patella, split
sir.
horizontally. Yes. Then, of course, you can use it, but then remember that I repeatedly said it is not the implant, but it is the forces. So when it is a vertical fracture, the quadriceps and the patellar tendon are not going to work in opposite direction. In fact, that will be much easier because quadriceps will also be split half and half. If you use simple wires there or screws, it will work very well. And over and above, I would put in the circlage. So answer is hypothetical. Question is hypothetical, a vertical fracture, difficult to see. The answer is also hypothetical that yes, it could be done with a little modification here and there.
Yeah, look, I would like to add that yes, we have seen some patients of vertical fractures, and as sir has suggested, we manage them with simple screws,
Screws.
two or three or four rows of screw in vertical, and that helped, and the patients mobilized well also after that. Yes, sir, we can manage them with.
This was a question from Chandrapur. So there is another question.
Dr. Gadegone asked that question?
No, sir, no, sir. Dr. Kulkarni.
Okay.
Dr. Srinath Kulkarni.
Okay.
So
Please.
there is another question. Does
If you can name the surgeon, it is good because he gets the answer also.
Yes, sir. Yeah, definitely. This is Dr. Sharma from Raipur. So can the principle work on lateral and clavicle fractures also?
Sorry?
Does the tension band principle work on lateral and clavicle fractures also?
Lateral to the clavicle, yes. I showed an example.
Yeah.
It can work. There is no problem. There is no. Is Dr. Sharma from Raipur or from Durg?
No, sir, from Raipur.
Raipur, he is it.
Yeah.
Because I know A. Sharma in Durg. He is son-in-law of my friend. That's why I was inquiring.
Say some Raipur, sir.
Okay.
So you mentioned about the complication of patella, this tension band, where the opposite side opens up. Sir, with the normal wires, the encyclopedic wires, can we avoid that complication?
No, that's why I went to length to explain the mechanism. Because we are putting it at the extreme fiber of the patella, and the pressure is also from the extreme side. Mechanically, it is going to open up. What we can do in addition, when we're passing those K wires slightly deeper, they probably stop it from opening. So in practice, we don't see so many of those because those two K wires, they keep the bone end together, but the pressure is always there to open it up. So either you can use additional cerclage wire more towards the articular surface that could hold it.
Okay.
But otherwise, it's difficult. It is always going to open up unless we follow the Levitsky's methods of putting tension bands on the side, which I just showed. It works very well. Even with the wires, it works very well. You don't have to wait for this. Couldn't show an example, but I had done these on the side, and they also work very well. Instead of putting the figure of it, you put two loops on the side and bend the K wires laterally. It works quite well.
Yeah, look, there is a question in my chat box.
Yes, sir.
If we use in patella rather than two, if we use parallel 3 or 4 wires in a comminuted zone fracture, will it work?
Yeah, it should work. Why should it work?
Yeah.
The only thing to control those 4 wires would be difficult. And you got to make sure that they are bent so they don't run away somewhere else in the body and you have to go for surgery. They should work. 2 or 3, more than 2 wires should also work. No problem.
And another question is, the AO has recommended the top portion, the proximal part, to be bent K wires, and distally they are kept just cut. So what would be your perspective on that?
One should bend both the sides.
Both the sides.
Both the sides, because it can just fly off from the other side. Both the sides should be bent.
Okay.
If I have not shown them there, that is artist's mistake. That means my mistake only.
No, it was there. In your slide, it was there, bent at both the sides.
Yeah.
Yeah, both sides should be bent.
Yeah, look, if you have another question.
Yes, sir. Yes, sir. From Professor Nicholas Santau, sir. What is the difference between cerclage wire tension in patellar fracture and anterior figure of 8?
See, anterior figure of 8 is proper tension band because it's going to convert the distracting forces of quadriceps and patellar counteraction and producing compression on the articular surface. While cerclage wire is just going to hold the two articular surfaces together. It's not going to take benefit of the distracting forces of quadriceps and its counter pressure. So it will be a weaker construct than the tension band wire. Tension band wire will have the advantages of distracting forces being converted. It is working on principle. As cerclage is a motley thing, just it doesn't have that strength as a tension band wire would have it. If there are two hard, very strong forces, tension band will hold while cerclage will give way.
So there are a few more questions by sir.
Yeah, go ahead.
So how to choose a diameter of K wire diameter and diameter of tension band wire? Does it depend on the fracture size pattern or the patient build?
Which one? The cerclage?
Yes, K wire also. K wire diameter as well as cerclage wire diameter.
No, usually recommended is 1.8 thickness K wire and 18 gauge wire cerclage, 18 gauge reel wire. That is the standard recommendation. One can use a little thinner when the patients are very thin and you find 18 gauge would be too heavy. One could use this way or that way, but otherwise there is no big deal. We need to change the thicknesses. If you use very thick wires, say 2 millimeter, 2.5 millimeter, then it is difficult to bend them in that tight situation. 1.8, 1.6 can be easily bent, and one also can get a special plier which can bend the wires at 90 degrees twice. One of my suppliers, Uma Surgicals, had made a special forceps for me. With that, I can bend them at 90 degrees as you see pictures. So it is quite possible there. Unfortunately, I doesn't made one for 2 and 2.5, 2 or 2.5 millimeter thicknesses. There was only 1.52 millimeter. But though for the design is very good, should be used more often than what is being used now. Um, let's see, but there is no great need. But one can go by the dimension of the patient of the patella, but not very thin. I won't go anywhere below 1 millimeter. Uh, Honestly, I would stick between 1.6 and 1.8 for the K wires and 18 or 20 gauge for the patella.
I think you must have got the answer. No problem. Next, Alok, you
Sir,
can.
another question is there. Sir, can you explain how to know the tension side of each long bones, tibia, radius, and ulna?
Sorry, I didn't get it.
The surgeon
Sir.
wants to know the tension side of radius, ulna, and the long bone femur.
Tibia, sir, tibia.
Tibia.
Sorry.
Tension side.
Yes.
See, ulna and femur are very clear. There is no argument. The dorsal side of ulna and the lateral side of the femur are tension sides. There's no argument. On tibia, it is difficult to make out exactly which is tension side, which is the flexion side, because it changes from side to side of the pressures, etc. So in tibia, we do not apply the tension side rule, but we apply the convenience side rule. If we have to apply a plate, we do not go for the tension side, which is the lateral many times. But one guideline, which is the tension side of the force, can be found out by looking at the X-ray. If you have butterfly fragment, then the broad base of the butterfly is usually on the compression side. The apex of the butterfly is on the tension side. So this is an arbitrary rule or a mechanical rule you can apply, but when applying plates in tibia, we will not worry too much, except for this particular. And this is one sign I know that if there is a butterfly fragment, then you can judge by the apex of the butterfly, but that will be always towards the tension side. And the broad base of the butterfly will be on the compression side. In tibia, the sides also change. So, but in femur, it is always the lateral side, and ulna, it is the dorsal subcutaneous surface. They are tension side.
Good, the surgeon did not ask about humerus.
There are
Because
few.
side is posterior, there is no doubt about
Doubt
it.
about it.
So
Go
there are
ahead.
few more questions there.
Yeah, go
Because
ahead.
yes, radial nerve is there. It is also the drainage side. People don't like that drainage side, but once you know the writings of Henry, and once you read that approach, Henry's approach of mobilizing the radial nerve,
Then it becomes easier. Yes.
Sir, another
drainage
question.
side.
Hello.
Yeah.
Sir, so this is from Kolkata. Dr. Arun is asking, how does the tension band principle acts in fractures medial and lateral malleolus?
Same principle, same way. So we take a medial malleolus, the deltoid ligament is attached below, and with the weight of the gravity weight, it is being pulled apart. So we relocate it past the wires and then put a tension band through the tibial herd, and it is then stopping the deforming force exerted through the deltoid ligament. So it works the same way.
So
Yes,
you
sir.
got the answer that the weight of the limb is the distracting force there.
Yeah.
Yes, or movement, that's the distracting factor. The gravity is distracting factor.
Gravity is the distracting force. Yes, Alok, next question.
Sir, you had talked about pre-stressing the plate in only simple DCP, or we can pre-stress the plate in LC DCP or LCP also, because it is said that the LCP should not be bent. This is Dr. Yash Parekh.
Yeah, as a rule, it should not be bent. You should always get a pre-bent one. But you can always bend LCP or locking plate between the holes. Between the two screw holes, you can bend it. And need to bend it sharply at a very limited way. And it can be done. It does not affect the strength of the plate.
Yes. And whenever we require to bend it that way, we can put two sleeves and then bend between the holes. As Saresh said it.
That's right.
So this is another question from Dr. A.S. Rao, Vijayawada. Does the tension band principle works when SS wire is passed through the CC screw, which is used instead of K wires for holding fragments in fracture patella?
Whether it works with the screw also.
Yeah.
Yeah, it will work with the screw. In fact, some people use cannulated screws first to compress it, and then through the cannulation pass real wire to make additional help on the outer surface, on the tensile surface to give the additional pressure. It will work, no problem. Those screws work like this.
Yeah. So once we are over with the tension band wiring questions, I think
Yes,
sir
sir.
can proceed with the potpourri. He is going to serve us.
Yeah. So we can.
Yeah, we can proceed further.
Yeah.
Then we
Please.
can proceed with the further lecture.
Okay. Start with the quotation. I'm sure our audience wonders why people like Dr. Chandak and Ashok Sham and Alok, they spend their afternoons just teaching people. The answer is here because they take it a serious duty and responsibility to teach facts and theories which ultimately applied at the patient by the student will decide about success and failure. As a true physician, they want to propagate their knowledge to the ones who are coming behind them so that ultimately our patients benefit. Whether your patient, my patient, is same thing.
Yes.
In fact, in orthopedic, they say patient doesn't belong to Dr. A or B, it belongs to orthopedic community because he goes from one place to other all the time. But this, I thought this worth appreciating the way doctors Chandak and Ashok are working on it. I really appreciate and I'm sure our audience also appreciate the same thing. We move on to the next chapter, which is Vhm Theory. Vhm stands for Bone Healing and Non-Union Theory. We have learned about how fractures heal for a long time. That is being taught to us. Works very well. But this is a new thing which I think we should all at least pay attention to because that will once we start believing it and see the effects, our way of treating fractures, particularly non-unions, is going to change. What the group, it is not one single person has put forward. They have a group of 9 surgeons who work together and they have come out with this. What they think is the entire area around the fracture site works as a bone healing unit. They don't say a particular organ, the periosteum or endosteum or marrow or what. They say everything, muscle, periosteum, ligaments, whatever comes in that particular area of swelling, it works as a bone healing unit. The unit produces a physiological response to its biological and mechanical environment, which leads to normal healing of bone. They don't want to separate, give responsibility to periosteum or endosteum or this or that. They said entire whole stuff works together in tandem and they respond to biology. That means if there is adequate blood supply or number of particular cells, osteocytes, or multipotent cells, or whatever histology, pathology, that works together. That's one. This is as biology. And second is the mechanical environment. Mechanical environment is what concerns us, you and me, and is our responsibility. But they derive this theory on basis of this is a gist of 3 theories called Perrin, Wolf, and Frost. So what is Perrin theory? Is of strain theory of Perrin is very well known. We have discussed it many times. Strain is the ratio of change in the length of the fracture line to the original fracture line. And the change could be either lengthening or shortening. And it is expressed as percentage of the or percentage. There are no units involved. This we have discussed many times, so I'm not going in more detail. I just put forward a strain change or change in length of the fracture gap or length of the fracture. If the length first is 10 centimeters and the change is 10.1 centimeter, then the strain is 0.1. That is about what 1% or 2% something. And this is what it is. If this is the fracture side, if it is not moving less than 2%, then we call it as stable. This is moving 2 and 10, and this is moving too much. So depending on how much it moves, the strain will come up and down. And then it goes to say, we define if it is moves between 2 and 10%, we call it is relative stability and a fixation, a fracture that allows small amount of motion when loaded. This leads to healing by calcium. If there is absolutely no movement, then there is no callousing, but bone healing proceeds with a different method, which is called direct from one end to other. And that mechanism is entirely different at the micro level. It heals, but it heals slowly, and we do not see an outside callus. So each stability level has its own advantages. If there is no stability, it's all unstable, then nothing happens. It all breaks down. We get non-union. Wolff's law is the shape of the bone being given, the amount and the structure physiological loads applied to it. If the bone has to have some load on it, if there is extra load applied to a bone over a long time, then it will become thicker. If no bone is applied to a bone over a long time, it will become thinner. That means a bone will respond to the load applied to it over a long time, not a day or over months. That is what the Wolff's law is. The shape of the bone in animals is subjected to Wolff's law. Depending on the function that they do, their bones adapt to that function. Bone is stronger or weaker depending on the load. A classic example of a paraplegic, he cannot stand on his legs, so he does not load his bones, femur and tibia, so they become porotic. But at the same time, his upper limbs are strong, they are more muscular. So if we take the x-rays of his bones of the upper limb, they will look normal. In fact, they will look more than normal. They have shown examples of tennis players that their right humerus is the humerus is stronger and thicker than the left humerus. We don't have X-rays of Djokovic or Nadal at this moment, but I'm sure somebody should do that research and find out how much thickness is. There won't be change because they load their right hand much more than their left hand. There will be difference according to Wolff's law. So is what Wolff's law is, the form follows function. Depending on function, the form will change. Frost will puts down a few conditions in which the same thing about the function of the function and structure. He says in the system in which mechanical loading affects the bone structure by altering the amount of bone mass or the arrangement to create a structure with an economical amount of material to resist expected load. See, nature is very, very frugal. It will use minimum possible things to do the maximum possible. In femur bone, if you see the cross section, there are strong lines, strong arches. Arches can withstand large loads. So that is nature's way of using minimum material to get the maximum amount of it. It's very mechanical minded nature is. So this is the same system. Frost has divided the things in any bone can be loaded into 4 zones. Disuse, when the strain is very low, there is absolutely no load. The bone mass and the bone strength will be reduced. As in paraplegic, I'm repeating, lower limbs, there is no strain, they cannot stand, it becomes porotic. And somebody is confined to bed for a very long time, 6 months, not walk, you'll find this bone has become very late. Adapted state is between 8 100 and 1500 strength when the bone mass and bone strength remains standard. If there is a normal weight, then the bone mass remains equally good. If there is overload, 1500 and more, then it increases. Somebody is doing too many exercises, taking too much load, like I said, a tennis player or somebody who's running for a long time, you'll find his bone, uh, the neck of the femur is stronger in long distance runners. So you are overloading it, the bone will respond to become stronger. But if you overload it too much, 10 times more, it's going to break. So there is a way of responding. Either it will respond by increasing the structure, or if you overload it, it's going to break anyway. Intermittent application of load stimulates the bone growth. That is what they say. This is also important, magnitude and rate of application. If you apply a moderate load over a length of time repeatedly, it will respond by increasing the strength. But if you apply a huge load, all of a sudden it will break. It will become overloaded and it will break. So magnitude, that is too much load, very rapidly, as a one stroke fracture. Moderate load, repeatedly, it will respond by become thicker and thicker. So both things are by the. He has applied this theory to also soft tissues, ligaments, tendons, etc., etc. And he calls them stretch hypertrophy rule, which states that intermittent stretch causes collagenous tissues to hypertrophy until the resulting increase in strength reduces the elongation and tension to some minimum level. So ligament initially will, if you put them to stretch, they will become stronger and stronger. But it will come to a, if it becomes thicker and stronger to a level that your applied strength doesn't pull it anymore, then it will remain static. So over and above what all these things say, that mechanical forces working on the bone affect its function in one way or the other. It also affects the way the fracture heals. That's the whole thing we want to do. Coming back to this biological unit produces a physiological response to biological mechanical environment, which dependent on all those three factors that we briefly discussed. This is a classic example. You put a patient in new slab and you get abundant callus formation and healing occurs in record 6 weeks time. Bone healing, you need all the tissue around that area. It is sensitive to mechanical stability. In the granulation stretch stage, it can be pulled apart almost 100% and nothing much will happen. After 2 to 3 weeks, the cartilage is formed and the ability to be pulled or tolerate the distraction or the movement becomes less. It comes down to 10%. Forcibly, if you apply too much play when it is in cartilage stage and pull it apart, then the whole thing will break down. Once the cartilage becomes calcified and you have laminar bone formation, the strain tolerance becomes even much lesser. It comes 2 to 5. And when you become 2 to 5, the direct healing starts if there is a bone-to-bone contact and the remodeling starts. Whenever the bone fractures, the terminal, when does the fracture healing is called complete? When the bone has completely remodeled. And for that remodeling, it requires no movement, 0 to 2% movement, which is almost no movement. Normal remodeling will start. When we see callus formation, we have come down to 2 to 5%. Some movement could have occurred, but nothing much for functional one. But remodeling will happen only at this low level. In splint traction, this native healing process will take place. There is no problem. But the problem with such treatment is that you have malunion, you have deformity, muscle wasting, and joint stiffness, local porosity because not weight bearing, and this was called as fractured disease, which was common accepted thing till 1940s and 50s. By 50s, people became very aware of all these problems they wanted, and the society also changed. It became more of an industrial society where people could not stay home for 6 months. They would be thrown out of jobs. So there was need to go back to work, need to be fit quicker and faster. So treatment started to avoid what is called as fracture disease, and the internal fixation thing came in. It was initiated to overcome all these problems, to get anatomical reduction and get the stability where you can move the joint. The aim was not to make him walk the next day. I hear a lot of people saying, I make him walk on the next day, full weight Derek. That's not the real aim of the fixation. The aim of fixation is to get anatomical reduction and ability to move the joint. If it is so stable that you can allow him full weight, you may also allow him to run the marathon if he is so confident. But as long as he is able to move the joints and keep the muscles mobile, the joint mobile, we have achieved the goal of doing a proper internal fixation. So what is the treatment? Man always perfects everything, and they created what is called an absolute stability by applying those clamps and other things. And for a few years, everybody thought that is the way to go, only to realize that primarily bone healing with no visible callus is something which will delay functional return to normalcy for a long time. So the thought process changed, and then we again said that callus is good, so we can mobilize early. People can go back to work early, and no need to go for the absolute stability all the time. Internal flexion below 2% callus does not form. To see quick healing callus formation, relative stability is necessary. If the fixation is flimsy and does not counteract the loads, then non-union will occur. So all this is to say that the fracture healing process is dominated by mechanical factors. The mobility or the stability at the fracture site will direct the way the fracture heals. These are the biological ways, but now other biological causes are infection could delay severity of injury, peripheral vascular diseases, diabetes, prevention, previous irradiation, major endocrine abnormalities, and smoking and use of non-eds. Most of them are beyond our control as orthopedic surgeons. We just take it as fate accompli. If it comes this way, wonderful. We go on and we say, okay, we'll do that. But there are certain things for which we are responsible. Additional important causes of non-union are poor surgery, increased injury to local soft tissue and poorly controlled dissection and excessive stripping of periosteum are the major causes of non-union. We often do not recognize this cause, but this is the fact. One has to be precise and very gentle at surgery to get good healing. Application of stiff plates or very large area of contact that will destroy the periosteal vascularity and also damage a lot of soft tissue. This we have overcome by changing the size and shape and the functionality of our implants. Delay in healing due to devascularization. Your surgical procedure or your implants are destroyed devascularization, delay will occur. Or you have used implant in such a way that there is no movement occurring at the fracture site. That means the healing is going to be very slow. If that happens, the implant may fail before the healing occurs. There's always a race between the bone healing and the implant. So if you have created a mechanical environment that there is no movement at all, no callus will be formed, the implant will fatigue and will break. So you will lose out there. And you see this kind of fixation, you can't but help blame the surgeon. It's a bad way of doing it without understanding the principles. And this kind of non-union is absolutely expected. Most non-unions are due to poor mechanical stability. The bone healing unit retains its ability to produce bone even in atrophic non-unions. This is the elements of the bone healing Vhm theory that even in atrophic non-union, there is no evidence of vascularity. It retains its power. Non-union is mostly due to mechanical reasons. Either it is too flexible, so the healing breaks down, or too stiff, the healing does not take off. So change in the level of stability will produce bone producing range. You have to bring it down to the 2 to 10%, so the bone will start forming again. The group maintains that the vascularity of the soft tissue is capable of forming the new bone again, provided its stability is controlled by one way or the other. And they have gone a long way to show how it works. To achieve appropriate state levels with suitable implants, that is their motto, that's what they achieve. Bone grafting and BMPs are unnecessary. Use them only when there is significant bone loss. In the gap, they say yes, you can use it, but there is no significant bone loss, then say just suitable implants and methods of fixation, you will win. No need to excise tissue from the fracture site. This is important. Cortical decortication creates supplementary bone healing unit. They say we should, if the old you should do a fish scaling thing, but no need to separate that, only to fix them together and fish scaling everywhere, fix it, it will work very well. The message is achieve appropriate strain levels at the fracture site. The existing bone, existing soft tissue will form new bone and no need for bone grafting. This example, there is a non-union and a proper stability was established. The fracture healed in no time. Healing with good callus because the nail is of adequate strength and adequate stability has been there, so there is a uniform callus formation. But in this case, a very thin nail has been used. So at the end of 6 months, there was very poor callus and the non-union site is coming up. An exchange nailing was taken in which a thicker nail was present. In good 5 months, there was no bone grafting. Reaming increases the bone marrow diameter. It increases the cavity so you can pass a thicker nail. It is debatable whether the reamings get out of the non-union side and lay down outside to stimulate bone graft. It's debatable whether the reamings really work as bone graft. The non-union. If there is a gap, of course, it will work like this. But if you are not open to fracture site, just simple reaming like in exchange nailing is very, very doubtful. What changes is the stability level. By putting a thicker nail, you have achieved relative stability of 2 to 10%. That's why the existing area, the bone healing unit, starts functioning and produces good callus in 5 months. Here we are, good callus in 5 months. Even distal tibia, everything, stability is maintained in this thing, good callus is formed. Here, in the fractured area, there is no implant, and it's allowed enough stability here, relative stability here. So the callus, there was movement between these fracture sites led to good callus formation. However, in this particular case, locking screws were applied all through to make it a very, very stable implant. So in 6 months to 8 months, it simply broke because no callus was formed and implant can last only so much. So it broke. What the salvation was only to use a big implant which allowed movement at the fracture site. Relative stability and the healing occurred without any bone graft. So changing the level of stability, creating relative stability at the fracture site promotes or restarts the bone forming unit at the fracture site. There is no need for extra stimulus by way of bone grafts, which when taken live produces more morbidity at the fracture site. Again, this picture here, stability is caused interflex screw has been passed, and also compression was applied here to produce more stability, and that made the trick. Fracture was healed in no time. Compression device was first very favorite stuff, but of late it is being relegated. It is recommended that when you want to apply compression, a good compression, either in tibia and femur, and to some extent in humerus, do not depend only on the DCP holes, but use this compression device, which I'm sure in your office, in your concerned operation theater, but is not being used at this moment. Bring it out and use it freely. It will give you rich dividends. Don't simply depend. If you are doing a serious non-union of femur or tibia, need to compress, use this device. You will be grateful. So this is the first generation version 1 that this is drawing of the version 2, but it works like that. Now, just improving the stability in this particular case helped us. At 24 weeks, there was no fracture union. It was removed, and the corset was given at 52 weeks. There was hypertrophic non-union. Patient found it difficult to lift weight. He was a pathologist, could not handle the microscope. So we had to do something. All that was done to use a longer plate and established relative stability at the fracture site. And in 10 months, there was solid union. No bone graft was used. So the message is take care of the stability level, work for relative stability, and no need for bone grafting. Same reduction screw. Carrying this thing further, recently this has been shown that if you just put 2 screws across, the healing will take place. And these screws don't have to be lax screws also. Just simple placement screws will also work, and fracture will heal. The authors have shown it in this case where the non-union insured at one side, they applied these 3 screws only as placement screws, and the fracture has healed. This is the article which everybody should read. However, be careful before applying this technique in practice. It may be even in Ilizaro, the same principle works. What is said is that you get the normal alignment and then compress it, which provides this. So you are again reduce the strain level to that zone where the bone formation will automatically happen. There's nothing else is required, just reducing the stability to and again, as I said, even if you distract it at a specified rate of 1 millimeter per day, you are again creating low strain levels at the fracture site, and you will form bone callus in distraction as well. So the principle works both ways in compression or distraction, because strain levels change both in compression and distraction. It's just example to say how the distraction bone has formed over the time period. I recommend that this article everybody should read. It will make you thinking. It will reduce your bone grafting incidence. It will also improve your fixation capabilities, because when putting a screw or not putting a screw, you will think of relative stability, and that will make all the difference. This one was shorter. If there are questions, I can take them.
Yeah. There would a patient who has a question is there in my chat box. Alok.
Yes, sir.
Who has had a non-union after complete stability by a plate. Can that be treated by relative stability, or that again requires absolute stability?
Can you repeat the question for me?
A patient who has had a non-union or a fracture stabilized by absolute stability goes into non-union. Can that
Yes.
be treated again by a absolute stability, or should it be a relative stability?
So if you already tried to achieve good stability, absolute stability, it has failed, then you have to examine why it has failed. Is there any other extraneous causes or not? And you have to answer that. But if it's a non-union of long-standing, was it a atrophic or what kind of?
The surgeon has posted the photograph of a femur plated with absolute stability. Plate has broken down. That is the picture he has posted.
Plate has broken down. That means there was some issue about achieving the stability. So in that case, I would think the whole technique should be reviewed and a better technique followed so that you get the proper stability this time and healing could occur. Principle cannot change. The technique needs to be modified depending on the situation. The principle remains that if there is instability and none has occurred, you have to produce stability one way or the other.
So there is a question. Hello, sir.
Yes.
On applying loads, we say that the bone grows. I mean, it increases in hypertrophy. So how to assess that this is a physiological load which we are applying? When to stop?
It's a hypertrophic non-union.
Sir.
Alok, I could follow. If you speak slowly and loudly, I will get
it. Sir, am I audible?
Yes, audible.
Yeah. So you mentioned about the physiological stress on the bone. It helps in growing of the bone. Yes. So how to assess that we are within the physiological limits? Like you quoted an example of exercise that it may fracture a bone. So what not to do?
What not to do?
Yeah.
See, you have to judge the stability of your construct. And depending on the situation, like if you have plated a tibia and you want to promote, then you have plated a tibia and you want to promote healing by stressing it. I usually I give them a weighing machine and ask from putting weight for about 10 kilo to start with. The guideline is pain. If at 10 kilos, they get no pain, then I say, okay, after a week, you go for 15 kilos. No pain, then go for 20 kilos. And at 20 kilos, he has got pain, I'll say, come back to 15 kilos. So how much to go is patient dependent, is to be taken by guideline is pain. If patient says pain, then you have to reduce the weight. Otherwise, go on gradually increasing it to the full weight bearing. Of course, always there is a time scale. You don't start put wearing weight at the second day. You have to give initial 2 to 3 weeks of non-weight bearing, and then you go on to do partial gradual weight bearing. The use of a weighing machine is quite useful, and patients are quite intelligent to use it step by step. That works very well.
We have more questions, Alok?
Yes, sir. One question for the previous talk. Any avascular necrosis cases of patella in circumferential wiring damaging the anastomotic ring or the polar vessels? This was on the previous talk which we had on tension band.
We have never noticed.
No, it's very unlikely to call avascular necrosis by circumferential wiring in patella. Very unlikely. It's very difficult to really squeeze all the blood supply. There is a lot of blood supply through both ends, so that is very unlikely. Very hypothetical question.
Sir, another question is, how should the fracture site look like after applying the principle with cancellous bone interface?
No, please repeat.
How should the fracture look like after applying the principle with cancellous bone interface?
I think.
How to?
Can you ask him to rephrase the question?
Yes, I'll do that. I'll do that.
Yeah, just ask him, because we are not getting what he wants.
What you want? The question needs to a little clarification.
So whether he wants on the physical characteristics of the graft or the stability or the graft positioning? Just ask him.
Yes.
Any other question by that time we can take up?
So that's it till now. Yeah.
So sir would be continuing with the
Yes, sir.
other part of the
Okay,
lecture. Yeah.
So all of us, so many teachers we see now, there is every day there are 8 to 10 webinars going, everybody.
Yes.
Why people are doing so much? To that, the answer is on a quotation from a book called Samson Wright. Samson Wright was a physician, was a physiologist, and his book was extremely popular between 40s and 60s. Up to 70s, it was very popular. It was the masterpiece called Samson Wright's Physiology. I had that book as a medical student in 1960. The first page had the answer why the teachers go out of the way to teach. And the answer is here. In the captivity, a Rabbi told his favorite pupil, "My son, more than the calf wishes to suck, does the cow yearn to suckle?" At that time, I didn't understand what is this, but I never forgot this article. And now when I have to go out and teach Tuesdays after Tuesdays, this is the answer. I'm sure Dr. Chandak or
Yes,
Ashok,
yes.
they would have the same feeling as expressed by this quotation. From there, this is the next part is very useful for everybody. When a patient with fractured neck femur comes, usually the elderly, etc., all he wants is that stop my pain. And whatever you do, put him in a Thomas splint, put him in a traction, you give him diclofenac or tramadol. You dare not give him morphine, but other things. He is not happy. Nothing happens. This is all the time craving. So how to control pain in fractured neck femur in one shot? Immediate pain relief can be obtained by blocking all the 3 nerves that affect the pain. These are these 3 nerves: lateral cutaneous nerve, femoral nerve, and obturator nerve. How to do that in one stroke? They are all contained in one fascia. It's called fascia iliacus. So you fill the fascia iliacus with ropivacaine, 40 to 50 cc of ropivacaine in adults, and with lignocaine also. And then we do that. Just a second, I think I have picked up the wrong presentation. I had 2 of 3 them here. Oh,
Alok, are we not getting his voice?
no, I made a mistake there.
Yeah,
Just
yeah, no problem, sir. Feel comfortable. We are comfortable. Ashok, that was a wonderful comment from Dr. Thakur. Why you are all hooking on to this webinar? So that was a wonderful. Rather than those few postings of "मुझे webinar नहीं करना है," but this is what the appetite of every surgeon is, to gain knowledge, to dissipate knowledge, and we got the answer today. Alok, you are muted.
So there are going to be 2 opinions always, for it and against it. Do whatever.
But I presume those who have posted that they did not want to
So
attend.
they are in minority. It might be just a forward.
They are also attending.
Yeah, it's a forward. Yeah.
And therefore they are posting.
Yeah.
Ashok, will we be able to help Dr. Thakur, sir?
okay, I got you.
Yeah, got it.
Am I visible now?
Yes,
you
sir.
are
Yes, sir, you are
visible.
visible.
PPT is not shared.
So to get over this thing, all the three nerves can be brought in one shot.
Your PPT is not seen.
Sorry?
Your PPT PowerPoint is not seen.
Yeah.
You'll have to share your screen, sir.
Okay. How do I do that?
Just come to the video panel
Oh.
where you can see us,
Yeah.
and you can see the share screen button, and just yes. Sir.
Yes, yes, perfect.
Okay.
Yeah, yeah,
Fine?
perfect. We are able to see.
So fill the fascia with Ropiocan 40 to 50 cc, 0.5% single shot, and some ligno can also be added. Now this is the way to do it. You have the anterior superior iliac spine and the pubic tubercle halfway through, and make three different zones on it. 1 centimeter below. Point of entry is 1 centimeter caudal to the junction of lateral and middle third. We already marked that, as you saw before. Marking is absolutely essential. One should not try without marking. And then feel two pops in this. This is a cross section of the skin. I'm going stage by stage at the skin, and this is the subcutaneous fat, then the fascia, the vessels, and then this is the pectineus fascia, iliacus fascia, and then under that is the muscle. And you can see the femoral nerve there, iliacus muscle, cutaneous nerve, and the obturator one. And this is the space which we need to fill. This space exists in this area, as shown by the black eye, and now shown with the magenta colored thing. This potential space, we feel that the analgesic, this Ropiocan, and that takes care of all the three nerves in one shot. This is a deep fascia and fascia iliacus. You have the first pop, you get, when you puncture the deep fascia, you get the first pop, and the second one comes when you puncture the iliacus fascia. You distinctly feel click, click, or some giveaway feeling, and it works very well. This is just another cross section to that. You can see here, this is the potential space, and here is a video which you can enjoy. It's made by Dr. Kekre, who's my permanent anesthetist. All required is a skin marker, 2E needle, some saline, Ropiocan. One should not replace Ropiocan. Is the right analgesic available, and that should be one. Some Ropiocan. Anterior superior iliac spine is. It's good to mark down. Every time you do, you should mark it down. That is the safest way. That is the pubic tubercle, and then you draw a line. Make three equal sections, and below the lateral section you have point of insertion. Lateral and middle 1/3, that's the point of insertion. At the first pop, loss of resistance, tears in the fascia. Then you push it down to 30 degrees, and then you get the second pop. That's it. Piercing the fascia iliaca, and then aspirate. When you push, it really goes very smoothly. So withdrawing and pushing is a very important step and should be followed. So this is a very good method and is safe for both residents and surgeons. Anesthetists, of course, can do it, but it's difficult to get them on the spot. But all residents, all surgeons should learn it. Even in casualty, this should be done in the casualty area. In England now it is done in the casualty itself. The pain relief is given there at the time. It works within the period and it can be repeated. While you are investigating him, you can repeat that dose. If you have the facility to put a catheter, that also can be done. But you don't want to put a catheter, the method can be repeated 2, 3, 4 times. In children also it can be used, same method, no problem. But you must read it before doing it first time, and this is one good example. Further to this method, this can be done with ultrasound guided. So in hospital where ultrasound is available in operation theater, they should use ultrasound method because that's more effective. But if it is not there, then even the manual method is very good. Moment you see the patient and diagnose this fracture neck, execute this block, and then do the rest of the thing, the patient will be ever so grateful. It lasts about 8 to 12 hours and it can be done again and again and again. In the post-operative phase, apart from doing everything else, we also give this block. Our need for post-operative analgesia is much low. So this is a safe one, this is a sure shot one. This is a block which every orthopedic surgeon can handle and should learn for the sake of his old patient. So that's all the short one, but this is very useful and I would like everyone to practice this in his own way. But first, read it properly, follow the steps, don't take shortcuts, don't replace ropivacaine with something else. Use ropivacaine and if required, lidocaine 1% as it's given there, and your patient will be very happy. There will not be any accidents or emergencies with that. So that's for today's presentation.
Thank you.
And if it, as you said, if it continues, then next Tuesday we can do part 2, something about the hip joints, vital but little known things about hip fracture. If we do that, I'm sure people will be happy, but depends on government whether they lift the block. I hope they lift the block so we are all happy and not to another afternoon. So if the question remaining or for everything else, we can do that.
Yeah, thank you very much, sir. That was very informative about fascia LHS infiltration. Alok, if there are questions, we can take up right now.
So there's a question.
Yeah,
Hello?
go ahead.
Sir, can this block be used post-operatively also?
Post-operatively, yes, I routinely use it.
Yes, he suggested perioperative. Yeah.
I use it perioperative, before, after, both. And you can repeat it several times, no issue.
So next time I'm going to try before the anesthetist gives the spinal. The patient is very painful for positioning. I would try before that.
Exactly. This is what happened to my colleague's wife. She was admitted at a different hospital, but she was aware of this block. So she insisted she receives it. And she got it before she was moved from bed to theater, and she was comfortable. She wouldn't go without the block. The anesthetist came to the room, gave the block, and then she went there. It's worth doing it. It's very useful.
We will try
And
definitely.
what I am repeating is surgeons should do it. If the anesthetists are easily available, it's fine. Otherwise, you should do it. The resident should do it. It should be done in casualty in a general hospital. It is that simple once it is mastered. It has to be mastered like everything else. But it's that safe and that simple. It is meant for casualty use everywhere.
In case of inadvertent intravenous or toxicity to ropivacaine?
Intravenous, I have no idea.
No, inadvertent small volume going into intravenous.
No idea. I can't. But in the 20 cc diluted to 40 cc, the volume matters. But we usually use 2 ampules of opium and then dilute it.
Okay.
Take it 50 cc and do it.
Right. Alok,
yeah.
In that case, more it works.
Go ahead with the next question, Alok.
So this is Dr. Pradeep Nimade. So obturator nerve is in true pelvis. and medial to confines of iliacus fascia. How will the drug reach the obturator nerve?
How does it reach the obturator nerve?
Yes.
I showed you it is in that obturator fascia, that facial space of that color. I can go back to that. It is working. This one, this face contains obturator nerve.
Yes.
Here is the obturator nerve.
And
Few
therefore,
more.
yeah.
So all three are in that space.
And
It is
therefore, he
all.
emphasized 40 ml.
It's not my innovation.
Yeah.
Worked out and works very well. And it works better if we have the sonographic control. If the ultrasound control is available, it's good. But in our country, it is quite tough to get ultrasound in the right place everywhere. So we should practice manual method and become good at it for our patients. It works very well.
So in the next webinar, Pradeep may tell us whether it works or not. Let us see. Okay, Alok, next question.
Yeah. So next question is there. Is it medico-legally safe for an orthopedic surgeon to put in a fascia iliaca block?
Yes. You are a trained MBBS doctor. This is for doctor level, and you had taken special training. You have read it. You have asked your anesthetist. You have worked with him, and it is safe. And it is also emergency. The anesthetists sometimes are not available for 2 hours. You don't want the poor fellow to fail. So it can be justified in any court of law. However, it is quite safe if you follow the methods. If you do misadventures, anything can be wrong. But yes, certainly it is safe.
Yes.
Medically, it is safe. Legally, it is safe. And we can defend it anywhere.
With all the precautions, yes, definitely. Alok, yes, you have a question, Alok?
That's it, sir.
That's it. So that was wonderful. So we are really thankful for understanding the principles about tension band wiring. And Alok, Amol is now very eager to summarize what he has learned. He is so happy. He wants to summarize. Go ahead, Amol.
Good afternoon, Professor Dr. Thaku sir, and all the viewers who joined this meeting.
Okay.
I'm sure that young orthopedicians like me would definitely benefit by your lecture today. And sir, these are the points which made an impression in my mind today, that when we are using a plate as a tension band, it must be pre-stressed. Also, how a tension band device is actually an anti-tension device. I clearly understood the point of insertion of K-wire in patellar TBW, and also why K-wire are backing out during olecranon TBW. Also, first time I understood why a horizontal figure of 8 tension band wiring has an advantage over vertical figure of 8 TBW, and use of cables and advantages of cables for compression and tension band wiring, and methods of twisting and advantages of twisting the wire in tension band wiring. These are all the salient points in today's lecture. And thank you, sir.
So nice to listen to a young lecturer who has learned so many points. Alok, you would like to narrate something or some things which touched your heart and mind? You are muted, Alok. Can you unmute yourself? Alok, you are muted.
Yeah. So am I audible?
Yes. Now you are audible.
So he covered most of the points. Sir was very clear that even the diameter of wires, like 2.5 and 3 mm wires, were disruptive for the blood supply. And rule of cables and how are cables made and how are cables better than the wires. He was very clear about the ideas. And when you pre-bend a plate, which screws to be inserted first? I mean, he was the reason why he gave about which screws to be inserted close to the fracture site and then go in the periphery. He explained it very beautifully. The principle of tension band wiring, destructive forces converted to compressive, which is the tension surface and which is the compression surface. Then he also explained us about the non-union part, the strain theory, the Wolff's law, the Frost theory. I mean, most of the things were covered, and about the physiological load, he mentioned that if it is more than 10 times the physiological load, then you may sustain a fracture. So there were like many good things which I think over a period of time we just try to neglect it. But these are all important points.
So it
So
was
I
really a
took
good
note of
learning
most
process
of
for
these.
all of us.
Yeah.
Yes,
Yeah.
Alok. Thank you very much, Alok, for summarizing. Thanks,
So
Alok.
there was, yeah,
Anything you wanted to say? Go ahead, no problem.
nothing. That was fantastic. I mean, even he was clear about the non-union reasons of non-union was another is smoking, which we find quite a lot in our.
Yes. So really, we have learned a lot with this presentation. Ashok, I'm sure if you have a question or
Yeah.
two, you can put your question also.
I think
Ashok?
I just can comment that this is one of these classic lectures that we are having
Yes.
on Tuesday afternoons.
Yes.
And lot of people are going, lot of questions that people have will get answered by this 2-hour lecture, just listening to them. And we should make this into one single, like a CME, all this lecture, and circulate among the postgraduates and amongst all trauma surgeons also, so that the principle and the basics get clear and we all are on same page when we are discussing and talking about various things, rather than when we are discussing very complicated cases. Sometimes the faculty themselves conflict with principles. So these things, these lectures make it very clear about basic principles that lie at heart of trauma surgery and bone healing. Thank you very much, sir.
Well said, Ashok. Really, it was wonderful, and that is the reason why so many surgeons, established surgeons, keep on hooking to his lectures. So let us have his next series also on next coming Tuesday. If we are having an opportunity, we'll surely do that, and we'll all be eager to listen to him. Thank you very much, sir. That was a wonderful participation. Any suggestions, any comments, or anything you would like to make? Thakur sir, we would be ready to listen. We'll be welcome.
I would really like everybody is to adopt that fascia iliacus nerve block for his hip fracture patient. That is such a gratifying procedure that each and every orthopedic surgeon in India should adopt that. Moment the patient is there, it should be given and see that the patient is very happy. The whole talk, that is my really sweet.
Surely we'll give our feedbacks in the next webinar. We'll be definitely giving you the feedback. And thank you very much. And thanks for that comment that why Ashok is going on in full swing, conducting this webinar in spite of few adverse postings. But yes, teachings and disseminating the medical knowledge is what the medical mind likes, the academicians like. Yes, thank you, sir. Thanks for that comment. We are really enjoyed with that comment. Thank you.
Thank you, sir. Thank you so much.
Okay.
Thank you, sir.
So over to you, Ashok. If you have to say something or some information, you can, if you want to like about the next webinar you want to address.
Yeah, we'll have the next webinar. If not in daytime, then we can schedule in evening.
Yes.
Whenever sir is free.
Okay.
So
We'll schedule that. Definitely we'll schedule. And we all learn with his lectures and principles. Definitely we'll go ahead with that.
Yeah.
Thank you.
Sir.
We are really fortunate to have you, sir. Thank you very much. Thank you. And Ashok would serve the virtual coffee to all of us now.
Bye. See you then.
Yes, sir.